I don't want you to worry about taking a test on this stuff, because if you read the question, they're all basically trauma-based anyway. And I'll go through what the trauma answers are. These are a little bit beyond just the trauma answers that you need. But just to remember that a hemothorax is a collection of blood between the viscera and the parietal pleura. Now, the question is why do you get it? And you have to remember that we deal mainly with traumatic hemothoraces, either iatrogenic or accident-based, but there are different causes of spontaneous. And for the lung, if you have bullous emphysema, somebody pops a bleb and comes in with a big pneumothorax, they can have blood. These things can be a real bona fide bronchopleural fistula with an artery there, and they will bleed a considerable amount. PEs, if they're large enough and the patient survives, will give you a hemothorax. Pulmonary infarction, clearly. Tuberculosis, people don't think about this, and we really have to keep this in the forefront of our mind. Tuberculosis is on the rise. I mean, just in our hospital alone, we've had 4 exposures in the last month. So you really need to keep that in the back of your heads. It's primarily a nursing home population, but it can be anywhere or anyone. And then AV malformations. That's generally seen in the younger population, so if somebody under 20. The other thing is hemangiosarcomas. And what you'll see is a chest x-ray that looks like the side is basically full of effusion. You'll go to tap it and you don't get anything. And so now with the advent of the CT scan, it's easy to make the diagnosis, but what you'll see is just a haze of blood vessels. And that's a very dangerous situation. For the pleura, if you have torn adhesions or endometriosis, please remember that in females, it's still a diagnosis. If you have a pleural effusion that's bloody and you don't have an explanation for it in a patient that's not had trauma, it's cancer until proven otherwise. And then people who have blood dyscrasia, thrombocytopenia, hemophilia, obviously von Willebrand's, and then now with the advent of current anticoagulants and the 3B2A or 2A3B inhibitors, it can be a problem. Thoracic pathology, ruptured aorta and dissection, particularly if they're leaking, they'll transudate through the pleura. It may not be frank blood, but they'll get a bloody effusion. And then remember abdominal pathology, all right? Just by the nature of the anatomy of the diaphragm, if you have ascites or blood in the abdomen, you'll get a pleural effusion. And so pancreatic pseudocysts, cirrhotics, or even a hemoperitoneum. So just remember those pathologies. What happens in this is that if you have a rapid enough accumulation of blood, you'll get hypotension. Now we think about it as blood loss, hypotension. I'm going to give you a little bit different twist on this because there's another pathology or pathophysiologic process that happens. Remember, you can accumulate easily 3 liters of blood in the chest and never know you did it. Okay? Big space will characteristically hold up to 5 liters of blood, so you can lose a lot in a very short amount of time. What happens is that if you're bleeding fast enough, you'll get a clot. It forms a stable clot. Ventilation and oxygenation becomes impaired. You develop mechanical compression of the lung. You can get a mediastinal shift in tamponade physiology, and you can also flatten out the diaphragm. And this is what I want you to remember, all right? Blood loss hypotension is a natural algorithm for us, but this type of physiology in the face of a hemothorax is not. And this is what happens. If you have a right-sided hemothorax, what happens is that you'll get accumulation of blood, you'll compress the lung, you'll then compress the right atrium, and so what happens is you decrease venous return and the patient becomes hypotensive. Okay, pretty simple. If you have a left-sided hemothorax, what happens is that the mediastinum will shift to the opposite side. And remember, if they're asking you about mediastinal shifts, particularly you guys in the early years, because I think this comes up on your portion of the exam, if it's fluid, the mediastinum shifts to the opposite side of the accumulation. If it's collapsed, the mediastinum shifts towards the side of the abnormal chest x-ray. So what happens is the mediastinum shifts to the opposite side, namely the right. You actually bend the cava. In other words, the heart will actually torque the cava, both superior and inferior, and then you'll decrease venous return, and so you get the tamponade physiology. So tamponade physiology is not just direct compression of the heart, it's how you affect venous return. Over time, even if you drain these, the clot is partially absorbed, but what happens is you get loculated fluid, because what's not absorbed is iron and protein. And you get these fibrinous septations. So then this fibrin just forms like a mesh. It forms a network in there. And then what you'll have is you get a peel on the lung, it entraps the lung, and then you get a fibrothorax. So that's naturally what happens to these things if they're not taken care of properly. The goal of treatment is you want to get rid of the blood and you want to re-expand the lung. Now the question is how do you do that effectively? General management options. If you have a spontaneous fluid accumulation in any chest, and I'll go through this with pleural effusion, unless it's a trauma, okay, trauma is a different animal, or unless you know you have an aortic rupture, you want to do a thoracentesis. You want to know what this stuff is, because you have haziness on the x-ray, you have no clue. You have a black and white picture on the CT scan, you still don't know what it is. You get it out, and any time you remove fluid from anything, be it abdomen, be it a cyst, be it the chest, send it for analysis. You have one shot at getting answers when you're doing any type of intervention in surgery, okay? So think about it and send it off for analysis. Now, if it's obvious blood, and particularly in trauma, you put in a chest tube, okay? Now, the problem is what do I do with that? What do I do when it doesn't drain completely? Well, your option is VATS or thoracotomy or some local fibrinolytic therapy, but this doesn't work very well. It depends on how old the accumulation is. Management of traumatic hemothorax, and this is where I'm going to deviate a little bit from the rote in the textbooks, because you have to think about it. You have to think about it in relationship to the patient. You just don't want to think about it in relationship to rote numbers. All right, everybody is different. Your patient physiology should be the primary indication for whether you go to the operating room or not. Meaning, if you put in a chest tube and you get only 700 cc's out, the book says, you can wait, but you have a hypotensive patient. So what are you going to do? Okay, I might have other problems. But you don't find anything else. You don't find a liver lac. You don't find a splenic lac. So where is your problem? More than likely in the chest. They've bled out rapidly enough that they've formed a clot. You're not going to drain. They have tamponade physiology, and you have a hypotensive patient. And I'm going to tell you right now that a negative exploration in surgery is not a bad thing. You don't have to be afraid of it, okay? If you have 1,500 cc's out of the chest tube in any 24-hour period or immediately, and it stops, this should prompt consideration to go to the OR. Even if it's just a VATS, okay, you can look. And then if you have to open, you can open. The positioning is the same. You're going to have a double lumen tube in, or even if it's a single lumen, you just tell your anesthesiologist to hold ventilation while you're looking. You can always start with a VATS and then determine whether you need to open or not. All hemothoraces, regardless of size, should be drained. Okay? You don't want to let them sit. They're going to fibrose. So maybe just a little bit of lung, but you're going to fibrose that lung. So initially, the drainage should be done with a chest tube. 32 French is fine. There's nothing that really says you need to put in a 40. You have to remember the pathology of a hollow tube is it's going to clot off anyway, so if 32 or their standard chest tube is fine. If you have a persistent retained hemothorax, so say you have a trauma patient, you've drained 800 cc's of blood, the chest x-ray clears, they're hemodynamically stable, but you still see that there's a problem, or you get a CAT scan and you see a rind in there. you don't put another chest tube in. Worthless. What's left behind is clot. A chest tube is not going to drain it, okay? That's when you should go to the operating room for an early VATS. Now, the literature is confusing on this. Some of them say within 2 weeks. I can tell you it needs to be done within 3 to 7 days. We've proven that here. It's in the literature. This is the ideal time to get in there with the scope. It's just jelly. You can get a Kittner. You can clean it out, irrigate it out, and pretty much get the job done without having to go to a thoracotomy. The other reason you want to do these early and you want to clean them out, it decreases the length of time on the ventilator, decreases hospital stay, decreases risk of infection. Okay. Sometimes if you have somebody that can't go to the operating room, which is rare, you can improve drainage of, say, a 6 to 13-day-old hemothorax with localized fibrinolytic therapy. You can put it in with a catheter, you can put it in through the tube. Effectiveness has not been proven. You're not going to hurt anything by trying it, but generally, I guess there's about a 30% success rate now with that. Remember that an undrained or partially drained hemothorax increases the risk of empyema and fibrothorax, all right? You have a scaffolding there, you're gonna trap this lung. Large chronic collections, meaning, say, these aren't trauma patients, obviously. These are patients who, say, have had a pleural effusion for 3 to 6 months. It's quite large. They haven't been compromised. It's been tapped, and they feel they need to be drained, or they tip the balance, and all of a sudden they come in compromised. Your history is important here. You want to get a sense of how long this has been going on, because if you drain these too quickly, you can develop re-expansion pulmonary edema. Now, the key here is length of time that the process has been going on. It has to be going on for at least a month, okay? So if somebody comes in and you get 1,000 cc's out, you don't have to clamp the chest tube. Let it drain, okay? They're not going to become hypotensive. You know, nothing bad's going to happen. Incidence of re-expansion pulmonary edema is only 3% anyway. And it happens most often with chronic pneumothoraces, not chronic hydrothoraces. CT scan is a diagnostic modality of choice to determine whether you have a retained hemothorax or not. Okay? Can't tell much by the chest x-ray. You can't tell where the diaphragm is. You can't tell where it's atelectatic or not. So the CT scan has basically been the diagnostic modality of choice. So some general management options. Most of the time there's an accompanying pneumothorax. You don't know the underlying pathology, particularly in a trauma patient. You don't know what they did. They've broken ribs, they punctured lung, whatever. So a good reason to put in the chest tubes. If you're putting in chest tubes, particularly surgically, so you're in the OR, you always want to put 2 in. One apical for air, so you get good positioning because air rises, and one on the diaphragm to drain fluid. Okay, just good general practice. Hard to do if you're in the emergency room, so don't even attempt it, because when the emergency room, 90% of the time it goes into the major fissure and it's badly positioned anyway. All tubes should be to negative suction through an atrium or pleurovac or whatever. Antibiotics are questionable, particularly in the acute phase. Unless you've sent it off for analysis and it clearly tells you it's infected, there's no good reason to start prophylactic antibiotics for a hemothorax. Okay? You remove your chest tubes when they put out about 100 and 150 cc's per day. And this is a question I always love. They always ask me, when do you want the tubes to come out? You need to think about how much fluid the pleura puts out in a day. How much? How much fluid does the pleural space make every hour? Yeah, you got the right idea.
500 a day.
So give me a number.
500 a day.
Not quite, a little high. Huh?
1 liter?
No, you put out, it makes about 20 cc's an hour. Okay, so it puts out 20 cc's, it reabsorbs 20 cc's. So unless you have lymphatic obstruction from a cancer, more than likely, or some other problem going on in the chest, all of this is reabsorbed. So do the math, you know. So anything under 150 is clearly fine, unless you've had trauma or unless you've operated and you're expecting unintentional blood loss from just a surgical procedure. All right? You can easily, the chest can easily handle this. The only time they can't handle it is if they're in congestive heart failure or they have some underlying medical problem where the lymphatic system is already overloaded. Okay? Some major points. If you have a hemothorax, drain it with a chest tube initially, okay? 1,500 cc's or greater on initial drainage. Even if it stops, explore them, okay? Even if it's a punctured lung, explore them. You just don't know. Lungs bleed a lot, and they just don't stop. And if they do stop, you're going to have a chest full of clot anyway. In a trauma situation, particularly if you have a puncture of the lung, they're real easy to take care of with the staplers now. Just staple off the section, you get rid of your air leak, you get rid of your blood, you clean them out, you drain them, you're done, okay? You're not sitting around for 10 days waiting for this thing to resolve. You have to be aggressive with these, okay? Follow-up CT scan for all these patients to determine if there's retained blood. Don't guess. I know you got an initial CT scan on admission. You've done your drainage. If you're happy with it and that chest x-ray is pristine and crystal clear, okay, fine. But if there's any question at all, run them to the scanner. It's no more expensive than a chest x-ray nowadays, okay? You want to do an early VATS at 3 to 6 days after injury for retained hemothorax, not over a week, okay? 2 weeks, too long. Can't get in there, already fibrosed. You're going to be converting to a thoracotomy. And then just remember, retained blood will lead to empyema or a fibrothorax no matter how small. You can accept some of it, but you know, you want to do the best thing for the patient, and this is a really major cause of infection in a lot of trauma patients. Okay? Questions? Yeah.
Sometimes you may get the patients as a delay. So in such case, what's your time of going back and then wash out?
Delayed meaning?
The patient had a trauma?
And it's been in another hospital for 10 days and they come in and you have a retained hemothorax, you take them to the operating room and you clean them out.
So no timeline?
No. Just take care of it. Thoracotomy is not a crime. You know, I know everybody has made it into a crime, but a thoracotomy is not a crime. Operating is not a crime. You've got to get out of the mode of non-intervention. That's what we do. Okay? And in these cases, a more aggressive approach to these patients results, number one, in better care for the patient, shorter hospital stay, less risk of complications, again, provided you don't have other things going on that will make the operation too risky for them. You know, so this thing about, and this is proven, it's not just my bias, although it is a bias, you know, this bit about we're going to run a interventional radiology for this, we're going to stick this catheter in that, and whatever. No, you can take care of it. Any other questions? And these are real easy to do. VATS in these patients takes about 20 minutes. You know, they come in, you run them back, you wash them out, you get your kit, and you're done. Or if you're going back for something else, or if ortho's going back for something else. You know, let ortho do their thing, turn them, clean them out.
Mary, what do you do with a patient that comes in after 4 weeks, 5 weeks, got a trapped lung, and a rind that's that mature, and you haven't seen them before, and so you now are faced with the problem of fibrothorax that has been delayed treatment. How do you handle that? What do you do at surgery to sufficiently re-expand that lung without creating more problems and do bigger.
Okay. I'm going to go part of this in empyema, but the ideal time to operate on these patients is either within a week or after 6 weeks. The worst time to operate on them is when we operate on them right now, which they call us at 2 to 3 weeks. Somebody with delayed presentation of a pneumonia because they were treated 3 weeks with antibiotics and nobody got a chest x-ray, and now they come in and they're infected. The 6-week period is what Dr. Griffin is describing. That's when you're going to get the trapped lung, and that's a very dangerous operation, but you have to do it. What you do is you just prepare them, you go in, it's a thoracotomy, you don't even try to do a fibrothorax with a VATS, that's just a waste of time. Just do a full posterior lateral thoracotomy. I choose not to use a double lumen tube in those because I need that lung to expand in order to determine my normal anatomy. Now what I do is you incise the rind with a knife, and you can tell when you get to lung because either you're going to see it or you're going to get an air leak. Okay, it's going to happen. And then you just gradually peel it off. It's actually, when they're that mature, that's quite easy. It's bloody, so you always have to have blood available when you go to the OR, but you can get a good re-expansion if you do it delayed like that. Only time you have to worry about it is if somebody comes in and says, oh, they've had they have a hemothorax, and this is where the history is very important. You don't have a history of trauma, and they're telling you that it is spontaneous hemothorax, and they have a trapped lung. Then what do they have? Huh? Yeah, it's mesothelioma. So you don't want to get stuck trying to do a decortication on a mesothelioma. So you really, really have to have a good history.
Question about the tamponade physiology you're talking about, and how you said on the left it kind of kinks the vena cava. Does that mean it's more prominent on the right side where it has direct
No, it's 50-50. The mediastinal shift is pretty dramatic.